right. Can you guys hear me okay? Probably hear me okay without the mic. But... Well, welcome. How's the day going so far? All right. Just the beginning of death by PowerPoint, right? All right. So first of all, my name is Nick Belsey. I'm an assistant professor of surgery at USC. I've been there for about 5 years. I am minimally invasive, robotic, bariatric trained, but I generally specialize in upper GI, so esophageal and gastric surgery and conditions. So I literally just got off the plane and rushed to get here. So if I'm flying through these slides, please slow me down, okay? Because there's been like go, go, go. All right, so we're gonna start with esophagus, and literally my goal is to kind of get through the topic, and then we can kind of work with you guys if you wanna. I think you guys have a break scheduled after this for 15 minutes. But I do have like kind of a mandatory one question in each slide, and then I have additional questions that we can go through if there's time left in the hour, or if you guys want to push through all the talks and then do all the questions at the end, whatever you guys want to do. It's probably better to kind of do the questions at the end of each topic if there's any objections to that. So, but we kind of, I'm with you guys the rest of the day and the first 2 hours tomorrow morning. So, all right, we'll go ahead and get started with something that's near and dear to my heart. So look at the esophagus, so just some basic view of anatomy. All right, so looking at the epithelium, the majority of it is squamous, all right, but in the distal 2 centimeters or so near the GE junction, it starts to become somewhat columnar. And then the orientation is left, right, left, meaning in the cervical region, the esophagus is more to the left of the midline. Under the carina, it crosses over to the right side, and then in the distal thoracic cavity, as it crosses over back to the left as it crosses through the diaphragmatic hiatus, generally at the level of the 7th thoracic vertebrae. Looking at the vascular supply, right, so the arterial supply is segmental. All right, so the cervical esophagus is supplied from branches from the inferior thyroid, the mid portion from branches right off the thoracic aorta, and then distally, there's an anastomose or arterial arcades off the left gastric artery. The venous drainage tends to parallel that of the systemic arterial flow, but there are collaterals to the portal vein near the GE junction. Thoracic duct, right, usually is found on the right side of the esophagus, and then courses over to the left behind the upper third. And the lymphatics, very important in terms of cancer, these extend longitudinally in the wall of the esophagus before continuing on the regional lymph nodes. That's very important when it comes to esophageal resections. All right, looking a little bit more closely at the GE junction. All right, this is the segment of the distal esophagus that is exposed to the positive intra-abdominal pressure. All right, and this tends to be the most important anatomic landmark affecting the competence of the GE junction in terms of reflux disease, which we'll get to in a little bit. So those patients have a sliding hiatal hernia. There's the phrenoesophageal ligament. It's not pictured here, all right, but generally that phrenoesophageal ligament is considered to be stretched. And the patients who just have reflux without a hiatal hernia, all right, that attachment of that ligament is actually closer to the stomach as opposed to being on the esophagus, so sort of a phrenogastric ligament, and therefore the intra-abdominal portion is shorter, which plays a role in reflux disease. Brief review of physiology, all right, 2 high pressure zones, one at the top, one at the bottom. The upper esophageal sphincter, or UES, that's generally, the majority of that is the cricopharyngeus muscle. And you have the LES, right, or lower esophageal sphincter at the GE junction. A brief review of the swallowing mechanism, right, so you initiate a swallow, the UES relaxes. Primary peristaltic ways will move the food distally into the stomach. Right, if the food doesn't clear with that, there are secondary peristaltic waves. Right, these come from the smooth muscle of the distal 2/3 of the esophagus. And then occasionally you'll see tertiary waves, which kind of a key thing to remember is that they're not peristaltic. So if you see those they have really no physiologic purpose. All right, what about reflux disease? All right, so what is reflux? Right, so reflux by simple definition is just gastric contents moving into the esophagus. All right. All of us have probably had that from time to time, and that's a normal physiologic process. But it becomes reflux disease, right, when these patients go on to develop troublesome symptoms and or complications, such as the esophagitis seen here. Right, it can often be debilitating, and as you guys are likely aware, it can progress to esophageal cancer. The whole mechanism is generally a weak LES. You'd be surprised how many patients I see, they think, I just have more acid than my neighbor, right, and that's why I have reflux disease. But no, it's an incompetent lower esophageal sphincter. Right, and it is a chronic and progressive disease. So generally you have a normal esophagus, and then this is non-erosive, right? So early stages of reflux disease, but over time, anywhere from 2 to 20 years, patients can go on to develop esophagitis that will heal with medical therapy to that won't, and then eventually can progress to Barrett's esophagus, which is obviously a precursor to esophageal cancer. GERD's a big problem currently, right? Up to 1 in 5. So take a look around, right? So a few people in this room likely are suffering from reflux disease. Over 20 million patients are currently taking proton pump inhibitors. Despite that, 40% still have symptoms. So there's a lot of people that are unhappy with their medical therapy. About 10 to 15% of patients with reflux disease will go on to develop Barrett's esophagus and varying degrees of dysplasia. And studies have shown that this increases your chance of developing cancer up to 40 times. So what are some causal factors? Right, so the main thing is the function of the LES, right? So there's the anatomy, right? So it needs to be within the intra-abdominal cavity, subjected to that positive pressure. And then also the tone. Right, as you're likely aware, the tone of the LES is increased by drugs such as cholinergic agents, anticholinesterases, and alpha adrenergic agents, as well as alkalization of the stomach and gastric distension. It's decreased by kind of the opposite of all of these, as well as beta agonists, all right? And then obviously the things we kind of ask our patients to avoid, right, with diet modification, nicotine, alcohol, chocolate, and fatty meals, all have been shown to decrease that tone, along with acidification of the stomach. It's also important to have a proper esophageal body function, meaning if that reflux is coming up, if you don't have any peristalsis, there's really no good way to clear your esophagus of that acid and bile and digestive enzymes. And gastric emptying is obviously also important on the other side. All right, so how do we work up someone with reflux disease? So as surgeons, there's a couple tests that we're generally going to throw at them, 3, maybe even up to 5 tests, right? So probably the most importantly is an upper endoscopy, right? This allows us to go down with our own eyes, assess the mucosa, rule out any other underlying pathology that may be explaining their symptoms, right? Rule out esophagitis, look for ulcers, is there Barrett's, is there any dysplasia, is there any evidence of H. pylori? And then generally these patients will get some sort of pH study. The old standard is a traditional 24-hour pH probe. The newer therapy is the 48-hour pH Bravo monitoring, which is placed at the time of endoscopy, which can be extended out to 96 hours. We will generate a Demeester score. What's a normal Demeester score? 14.72. I come from the land of Tom Demeester, right? So we carry it out to 200th place. But anyway, so anything less than that is considered just physiologic reflux, but today is still the gold standard for diagnosis. Esophageal manometry, right, very important assessing esophageal motility. This is important, especially when patients have dysphagia as one of their main complaints. But generally, there's kind of been a push towards not getting that, and it's not necessary in all patients. And also important is an upper GI or barium swallow, right? I tell patients this is kind of like my roadmap for surgery. It gives me a good look at the anatomy of the esophagus and the stomach. It'll show a hiatal hernia. It'll show, maybe even show reflux. We actually do we call a video esophagram, so we actually record a little bit of video and watch them swallow in real time. There was a study done many years ago that we showed that if the motility on the video esophagram was fairly normal, that the findings on manometry did not alter our surgical plans. So, getting away from this and away from the other probe in the nose is a little bit more patient friendly. So patients like that, but occasionally we still need to do it. All right, so how do we treat it, right? So diet and lifestyle modification. Does this work? So about 5% of the time, right? If you see these patients, they come into your office, they're not pleasant, right? They're very unhappy because they're eating a very bland diet, but they're able to control their symptoms. So we ask them to avoid all these kind of foods, the double-double from In-N-Out and the fries and the carbonated beverages, caffeinated beverages, citrus fruits, marinara sauce. We ask them to elevate the head of their bed, maybe go out and buy one of these pillows or try something more holistic. So, but again, with diet and lifestyle modification, only about 5% success. So generally go into medical therapy, all right? So antacids, these are good for the social situation, right? And then H2 blockers are the original drugs that were described to treat reflux. But now most of us, generally will go to a PPI. I think as surgeons, most of the time they come to see us are already on a PPI. If they're not, why is it important to put them on a PPI? You guys know? This come up on the oral boards as well. So you want to assess their response, right, to PPI because it's a predictor of how well they're going to do with surgery. All right, so who gets surgery? All right, so those that fail medical management, right? So generally anywhere up to 2 to 3 months of medical therapy, a BID, PPI. Those that go on to develop complications of reflux disease, right, being esophagitis, stricture, chronic aspiration, right? And we have patients who just have asthma, never had heartburn a day in their life. Pulmonologist sends them over for a workup. They get an anti-reflux surgery, and they can generally throw their inhalers away. More increasing over the last couple of years, right? You guys are probably aware of all the FDA warnings that have come out about the chronic effects seen from long-term use of PPIs, right? Increased incidence of C. diff, community-acquired pneumonias, low magnesium levels over the last 2 years is chronic kidney damage, right? And the more latest one I heard was dementia, right? So the good thing is if you're dementia, you forget you have chronic kidney problems and elevated chances of having a heart attack, right? So, and then Barrett's, and Barrett's is kind of a unique situation because you really only want to operate on the symptomatic Barrett's patients. So patients, granted most patients with Barrett's are symptomatic, so it's not a problem, but if you have someone who's purely asymptomatic, because Nissen per se has been shown to not really alter the cancer risk. So, all right, so looking at surgical therapies, right? So the traditional Nissen Fundoplication, right? Rudolf Nissen described this in 1951. Initially it was done open. I think the first laparoscopic Nissen was described in France in 1991. So generally it can be done lap, open, or robotic. The key steps, right, are generally going to be your choroidal dissection, right? You're going to open up the hiatus. You're going to mobilize that distal esophagus to ensure an adequate intra-abdominal length of about 2 to 3 centimeters. And generally we're going to close the hiatus and divide the short gastric vessels, right? And then we're going to create a 360-degree fundoplication around that GE junction of about 2 to 3 centimeters in length. And granted, these doesn't need to necessarily go in this order. How many people start on the left? Start on the left side when they do their Nissens. Is anybody here doing Nissen? You guys have seen Nissens, right? So, but some people start on the left, right, and divide the short gastric. Some people start on the right, the gastrohepatic ligament. It generally involves a hiatal dissection, except in pediatrics. I know they're getting away from potentially doing a full hiatal dissection. So, but kind of key buzzwords you want to say, or look for if you're trying to describe how to do a Nissen. All right, then we have varying degrees of partial fundoplications, right? The Dor Fundoplication is an anterior 180-degree wrap, right? Very commonly used after a Heller myotomy. All right, a Toupet Fundoplication is kind of my go-to choice for a partial fundoplication, not so much after a Heller, but after if there's any kind of dysphagia, right, or any kind of dysmotility on any of their workup. And then generally thought of it's a bad idea to do a full 360-degree wrap, although some of us can argue for a couple hours about whether to do a full wrap at all. Then there's various endoscopic methods that came out, right? So this is Endocinch, which was a plicator that was used to try to buff up the LES. This is the gatekeeper device where they were placing these little kind of plastic, bumpers in there to try to beef it up. This is the like esophagus, right? So the plicator. Stretta uses RF energy. And then this was Enterix. This was involved in injecting a polymer into the lower esophageal function, or into the LES. Anybody know what happened with this device? It was recalled in 2005. So because there was about 11 reported full thickness penetrations of the esophagus, and one patient they actually injected into the aorta. All right, so needless to say that's not around. So, but if you've been around long enough, this all kind of came out in the mid-2000s when there was all that big hype about incisionless surgery, right, and scarless surgery. So, and some of them are still around and still have their effects and roles in the care of the reflux patient. But for most of the time, the long-term data hasn't really panned out to be as durable as the traditional surgery. Magnetic sphincter augmentation. How many of you guys are familiar with this or have seen this in your training? So this is kind of one of the up-and-coming things. So the device is made up of rare earth magnets. Rare earth are designed to never really wear out, and they're encased in a titanium bead. And the idea is it's placed around that LES, just like the wrap is, right? And it tends to augment the native function of that LES. So there's no anatomical distortion. It's non-compressive. A lot of people think it's like a zip tie or something that goes. Anybody remember the angel tick device? So, essentially it was like a lap band that was placed around the GE junction. The problem is it didn't stay there, right? So it kind of went away. I think it was the early 70s. And it's there's different sizes for the esophagus, and it's MRI compatible, which is good because you're putting an implant in. They can still have an MRI. up to 1.5 Tesla. So how does it work? So the design allows augmentation, right, without compressing the esophagus. So in the closed state, these beads are all kind of resting on one another, right? So it's not sitting on the esophagus. And they provide about 15 to 25 millimeters of mercury of pressure. And I'll show you in the next slide how that actually affects reflux. But then when you swallow, you're able to expand the magnets, overcome that resistance, and eat normally. So this kind of shows this. If you're familiar with manometry, right, normal peristaltic pressures of the esophagus generate anywhere from 35 to 80 millimeters of mercury in a normal esophagus. Normal gastric pressures are anywhere from 5 to 10 millimeters. So by that device being placed here, it generates about 20 millimeters of mercury. And so the good thing is you can overcome it with swallow, but it also allows patients to belch and vomit, which, if you're probably aware, is a significant side effect of the Nissen. So pre-implant, this is kind of what the valve looks like, and then post-implant, this is what it looks like. So you can see a noticeable difference there. So what about the heel repair? Show of hands of how many people have done this surgery. One guy in the back. So I think some of these are more of historical procedures, right? But here the heel repair was to take the lesser curve, both anterior and posterior portions, and he kind of imbricated that, over itself, and then you tethered it to the median arcuate ligament just anterior to the aorta. Classically was described as doing intraoperative manometry to achieve a desired LAS pressure, and this was a big procedure for those surgeons who believed in recreating the angle of His. All right, Belsey Mark IV. All right, so this is generally done only through the chest, whether it's open or through a thoracoscopic approach. You're going to open up the hiatus and mobilize the esophagus and distal stomach, and you're going to place these 2 rows of sutures and creating this kind of inkwell, and this is basically like an anterior 270, or it's like an anterior toupet done through the chest. Collis Gastroplasty, all right, used to lengthen a foreshortened esophagus. So this becomes kind of a necessity sometimes if you have these large paraesophageal hernias and you're worried about a short esophagus. Show of hands how many people have done a Collis or seen one. Yeah, so I'm not us surgeons, we can argue about whether you believe in the short esophagus or not. So, I do a lot of laparoscopic transhiatal work and esophagectomies, and so I think I can mobilize all the way up to the hiatus or the clavicles if need be. So I'm not a believer in the short esophagus, but Steve Demeester, who I used to work with, he did Collises on probably 20% of his patients. So, but again, so if you're worried about a short esophagus, you don't have that intra-abdominal length of 2 to 3 centimeters, you need to give consideration to doing it. This is showing how to do kind of a wedge Collis gastroplasty. Just take sequential firings and wedge out a piece of the stomach, doing it over a bougie. Laparoscopically, it's been described kind of putting an orville down, punching a hole in the stomach, and then firing up along a bougie to do it that way. All right, so what operation do we offer these patients? Well, it is multifactorial, right? So we have to kind of weigh the patient's comorbidities. What do they want versus their chance, they have a hernia, is it going to recur? What are their chances of complications, right? Is there any underlying dysphagia or esophageal dysmotility? As I alluded to earlier, most of us, I think, would do some sort of partial wrap as opposed to doing a full 360-degree Nissen. Again, the foreshortened or short esophagus, consider adding a Collis. Morbid obesity, right? This shows up from time to time. You want to consider doing a Roux-en-Y gastric bypass. Patient with a BMI of 35, the failure rate of a Nissen is about 30%. All right, have people done it? Yes. So if they give you something like that, what are you going to do? You tell the patient to go lose weight, right? What do? They come back in 6 months and they gain 10 pounds, right? So you guys, if you're not there yet, you'll get there. And then obviously if someone's been in the abdomen, you may want to consider going in the chest, although I do a lot of redo surgery through the abdomen. So what are the results? So this is kind of what I alluded to earlier, right? So you want to know your patient has typical symptoms, right? Heartburn, right? Regurgitation, maybe some dysphagia. You want an abnormal pH study, again, a score greater than 14.72, and you want them to respond to PPIs, all right? So if they come into your office and all they have is the globus sensation, I just have this little lump in my throat and I have a cough, you got a normal pH study and they tell you I take Nexium, it does nothing for me, all right? You got to really look hard to find something else wrong with this patient, all right? Because it's sort of these LPR, laryngopharyngeal reflux symptoms, the success rate's not as well. So you really try to, you really want patients who have typical symptoms, an abnormal pH study, and then, some kind of response. I always ask my patients, well, how much? 60%, 70%? And I always document the response to the PPIs. All right, complications.